Okay, so I'll go ahead and just get started. What I want to say is first to everybody today is thanks for joining me. It is a long day. Each day is filled with so much learning. And then today was all bone and mineral and calcium and phosphorus and vitamin D. And then you are picking to do more of the same. So kudos to you. Maybe you just kind of, keep it easy and you keep it one topic per day so you can remember it. Whatever the reason that you chose this workshop, hopefully we can make it worth your while here. The way that I have it set up is I have three cases. Cases are kind of in air quotes. The last one, you'll see why I say that one is a sort of case. It's more just a platform for discussion. We're a much smaller group than the entire review course attendee list. So I think we're about 40 or so. So please feel free if you want, you can even unmute yourself. I don't have any kind of time limitation on these slides. It's actually designed to be shorter than the hour and a half so that we have time for a discussion. And I also can see the Q&A box too as well. So feel free to enter text in there as well. Okay, so we'll get started with the first case. You're seeing a 76-year-old man who is admitted for hip fracture after falling at the airport. His current symptoms include muscle weakness, especially in the thighs and the shoulders for the past 1 to 2 years. His past medical history is notable for hypertension that was treated with a thiazide, and he also has a history of non-invasive prostate cancer that was treated with a suprapubic prostatectomy 4 years ago. His medication list is notable for thiazide. On exam, he has moderate proximal muscle weakness, otherwise fairly unremarkable, and his plain x-rays of the hip and pelvis show moderately severe osteopenia. Shown here are his labs. We'll just walk through them. His calcium level is 8.9 milligrams per deciliter. His phosphorus is 1.4 milligrams per deciliter. PTH is 54. 25-hydroxy vitamin D level is 39 nanograms per milliliter or 97 nanomoles per liter. And his fractional excretion of phosphorus is 25%. And his 125 vitamin D level is 33 picograms per milliliter. Well, that's interesting. I didn't know people could edit the screen that I can see. There's no problem at all. I just didn't know that that was a feature in this workshop. Okay. Does any brave soul want to say how they're interpreting the labs? I used to give this workshop live. It was much easier to do engagement. So feel free to put things in the chat. If not, I will keep talking. If we review them again, essentially what it's really notable is that the calcium level is okay, but the phosphorus is quite low. I can never remember the exact normal reference range for my lab, but for me, if I see less than 2, I go, oh, I want to call a friend. Less than 2 is no good. That's quite low. And the PTH level is the normal range, 25-hydroxy vitamin D is okay, and the PFAS is 25%. Is that high, low? What would you expect for that one? Probably low, and we'll walk through that in just a minute. And the 125D, I think that's what's giving it away. Someone has already anonymously, you should take credit, this anonymous person has already given what they think the answer is TIO, or tumor-induced osteomalacia. So let's let everyone catch up. The whole goal behind this, I know you guys have had multiple exposure or kind of repeat references to hypophosphatemia and TIO at this point today. So we'll just walk through it. So the first step really when you see a low phosphorus is you want to do what we call the fractional excretion of the phosphorus. So a lot of you might remember from your general medicine training is the FeNO. You all remember doing the FeNO when you're trying to figure out what type of renal failure it is when their creatinine is rising. The fractional excretion of phosphorus is just the same. There's actually no magic in between it. I know oftentimes we often go to whatever online calculator is using, but essentially what you're looking at is you want to look at the urine phosphorus level and you multiply it times the serum creatinine, then you do the flip. You do the serum, then you divide it over the serum phosphorus times the urine creatinine times 100%. A lot of times you'll see in the literature and also in reference guides, they also refer to the TMP, the maximal kind of the tubular reabsorption of phosphorus. And I think that probably makes more sense to people who are more the phosphorus experts. They like to think in those terms. You can see those were in Dr.
He's frazzled. I'd be frazzled too. And does he take, I've never
Uh,
asked, does he take the bridge
one moment, I'll just
collapse?
see if I can mute some of the attendees, that part. There we go. Okay, sorry for that interruption there. I do hear some background noise from others, so I'm just gonna ask a few more to unmute. Okay. Okay. Where was I? So I was thinking about saying, okay, do you expect to see a lot of essentially the phosphorus spilling into the urine? If you have a very low blood level, then in theory, your body should be wanting to be holding on to it or reabsorbing it. And if not, then having a high excretion is going to be an abnormal sign. So typically, if a patient is hypophosphatemic, a normal fractional excretion of the phosphorus should be less than 5 to 10%. And ideally, in terms of when you want to collect it, you want to do it as a morning void because there are some diurnal patterns to it. You want it as a second void of the day, fasting. And in case you're curious, the peak is usually around 4 a.m. and the naters around 11 a.m. So practically speaking, what you can ask patients to do is to go to the bathroom. First thing they do when they get home, drink a large glass of water, go to the lab, bring more water so that they can urinate again and offer that collection. Okay. So what diagnoses need to keep in mind for low phosphorus? Someone jumped to TIO already because probably we've been mentioning it a lot. I did give away the answer in it. But what diagnoses would you have to keep in mind as a general rule when you say hypophosphatemia? Does everybody have TIO? C76, that's why we thought he had TIO. Well, I think it's nice to take a step back, kind of go back to your general training days, before you went all specialty, whatever led you to the path where you are right now. For me, it's all the way back to medical school. And when you say low phosphorus, there's kind of like three big categories. Is it because of the gut, like you're not getting enough? It's malabsorption. Is there any kind of internal redistribution that's going on, or are there any renal causes? And that's what we'll really focus on. When we say renal, I think of it specifically as a renal leak. You're losing it. You're not reabsorbing the phosphorus as you should be. Let me see if I can actually, 1 second, if I can. I don't know if I can, I was going to see if I can get rid of this annotation, but I seem to be only able to add more to it. So we'll just leave it be. Hopefully you all don't mind that. Okay. So what I wanted to do is kind of walk through the reasoning of why this person answered TIO. So what are all the different factors that affect this phosphorus balance? So the one that we're very familiar with as endocrinologists is the PTH level. So PTH, what it does is it inhibits the renal reabsorption of phosphorus. So if you have a very high PTH level, then you can't reabsorb it like you should be. So you're spilling it out. PTH also stimulates 1-alpha hydroxylase, so you have an increase in 1,25 hydroxyvitamin D levels. In contrast, as has been reviewed earlier today, FGF23, while it also inhibits the renal reabsorption of phosphorus, so leading to low levels of serum phosphorus, has the opposite effect on 1-alpha hydroxylase, where it suppresses it. And so what you would expect to see if you had low phosphorus, but you have a normal or a low 125 hydroxyvitamin D, then you can start to suspect that maybe there's some FGF23 excess going on here. What are things to keep in mind? The FGF23 secretion is actually stimulated by increased dietary phosphorus absorption. It increases the 125 vitamin D, as I already pointed out, and that's what's its most helpful diagnostic feature. And we also know that it increases circulating clotho. As we've reviewed already today, other causes of abnormal FGF23 levels can be either acquired causes, such as tumor-induced osteomalacia, TIO, which is exactly what this case was designed to be set up for. It's also elevated in patients with end-stage renal disease, and there can be congenital causes as reviewed too, such as XLH, ARHR, and ADHR with their attached gene mutations as well. So if you had a younger patient that you were worried about that you needed to evaluate TIO, With a younger patient, you would have to do consider if you wanted to do any kind of genetic testing for these causes of hypophosphatemia and elevated FGF23. So if you suspect tumor-induced osteomalacia, what you would want to do next is try to do imaging. Oftentimes they are associated with some soft tissue masses or growths. So it's actually really important to do a comprehensive physical exam in these patients. If you somehow are able to palpate something, that's exactly where you start. You would order that kind of dedicated anatomical imaging, MRI or CT around that soft tissue mass. More commonly, when I say common, TIO itself is not that common though. It's really hard to diagnose. Like it can take years, 3 years, 4 years, 5 years after suspecting someone has TIO before you can even do any kind of positive imaging. Just 1 second. Okay. And again, if I'm muting you and you unmuted yourself to ask a question, feel free to unmute yourself again. I'm just trying to eliminate the background noise. What I have listed here are other possible whole body imaging. That's more likely what one is going to have to do if you're trying to diagnose TIO, whether it's a scallion-based PET CT scan, with these variations, depending on which one is available at your institution, or an octreotide scan. There's pros and cons to them. Specifically, what I mean though is that there's different specificity and sensitivity of them. My sense is that the field is moving more towards this gallium-based PET CT scan as the first choice, but you can still also do an octreotide scan as well. Based on that, if you were to find something, then you would move on to the anatomical imaging. So most likely what's happening is that patients will have this unidentified source, and then they do this whole body imaging, and then you can order an MRI or a CT scan. Occasionally, you can have a source, but not really, you can still suspect a source in the whole body, but nothing be there on the anatomical imaging. And you can refer to specialized centers. For us here in the US, it could be, let's say, like the NIH, the National Institute of Health, for consideration of venous sampling of major veins, to really kind of you can do kind of a step off of sampling of FGF23 levels in different veins to really try to localize the source there. All right, I was just checking the chat. Oh, I didn't realize that there's two chats. There's a chat and there's also a QA. So I appreciate everyone for the backup for the reminders about the background noise. Okay. In terms of the treatment for TIO, the ideal would be removing the tumor surgically if you could. That being said, I think what ends up practically being are the traditional ones are either oral phosphate plus calcitriol. And those are with some caveats. The caveat with the oral phosphate is that one's really tricky because if you think about it, let me go back on this slide. So what are the reasons why would you give the low phosphorus? Or why would you give a phosphorus supplement? So this patient was symptomatically low, right? His phosphorus was 1.4. To me, I start to get concerned when it's less than 2, and particularly if they have symptoms. What I will say, I meant to say this at the beginning, and I totally forgot. One of my favorite endocrine questions I like to ask fellows are, what are kind of the endocrine causes that you think of for proximal muscle weakness? Hypophosphatemia actually is one of them. Another one could be steroid access, like corticosteroids, and then also 25-hydroxy vitamin D2. So once you're sure that you don't have any kind of those factors on board, there's no other explanation for the muscle weakness, then you can presume, okay, this is symptomatic hypophosphatemia. The reason why I say that it's tricky though is that if you are supplementing the phosphorus to try to get him to a level where he's less symptomatic, the problem, if you go back to this chart here, is there is this feedback loop, so to speak, where it almost feels like you're kind of like feeding the FGF23. So you don't want to give so much that you're completely normalizing it like into a high range, because it's almost going to make this condition worse. You really want, a very light touch, just enough, so that you are not exacerbating the condition. Commonly, patients are also given calcitriol or 125D since those levels are low, also to try to help with this overall balance, just to kind of keep everything even keeled, even though that's off-label use of calcitriol. But the danger or the concerns with the phosphorus and the calcitriol, you do have to be mindful of nephrocalcinosis though. So checking their 24-hour urine calcium levels, you can even do baseline imaging would be a good idea for those patients. More excitingly, as Dr. Wine had covered in his lecture though, is that burosumab is now available as a monoclonal antibody to FGF23. And so that has really been probably the go-to. I think as people try to sort through essentially not safety considerations, but long-term, like what are you trying to achieve for these patients? How long can they be on them? It is FDA approved for TIO, and it is shown to help improve their quality of life measures. So it does make sense to do, though I think a lot of people will probably start with these kind of more considered traditional supplements first. And then if that's not working well, since patients don't tolerate oral phosphate supplements well in general, then trying to prescribe the burosumab. One thing to keep in mind with the burosumab, though, is that it doesn't prevent the progression of TIO, and you also can't reliably measure and interpret the FGF23 at that point. So you're kind of in a unknown territory in terms of what to do and monitoring the burosumab beyond going by the patient's symptoms. The idea ultimately would really be, again, if you could surgically cure or get at the root cause of whatever was causing the TIO, say any kind of primary malignancy that was associated with it. Okay. So if we were to, just to answer answer this question for TIO, the 125D, you would expect it to be low. The tricky part is it also can be in the normal range too. In endocrinology, I'll say things that are like inappropriately normal. That would be my category of inappropriately normal. So that can be tricky. But also what you want to do is take a look at the PTH level, right? Because if the PTH level is high, then you would expect the 125D should be high too. So it's actually looking at all of them together is important. Okay, so if we were to summarize this first case, what you want to keep in mind is that the second void morning sample is most helpful. Urine sample is most helpful to determine the source of the hypophosphatemia. Your 125 hydroxyvitamin D will help distinguish the causes of the renal leak of phosphorus. The FGF23 is predominantly from bone as a source, and the abnormal FGF23 levels, they may be due to either acquired or congenital causes. Someone's asking what preparation of phosphate do you use and how often? I know that's a great question, because I'll try to find this chart, see if I can find it. I've seen Dr. Sharon Burnett, but we share it before of all the different ones. And essentially I always go by like whatever you have available. I don't know if you have this problem, but we had the same problem where the manufacturers seem to be out of stock. So honestly, I don't have like a personal preference of which one I go to, whether it's KPhos or NutriPhos. I do try to keep in mind that there are different amounts of sodium in some versus the other. So, for example, if I was worried about high blood pressure for these patients, I'll try to go for the one that has a less sodium amount. I don't have these numbers committed to memory clearly, or I'd share them with you. So I'm always double checking this chart to look up how much one versus the other has. I am also mindful, I don't know if it's the same for you and where you're located, where you practice, but I do find the names very confusing too. They're always kind of hyphenated, like, hey, NutriPhos, and so I always have to double check exactly which one is in the packet or pill that they are receiving. What I will say though is good old fashioned things like cow's milk is a great source of phosphorus. So I do try to encourage patients to get as much dietary phosphorus as they can to help supplement it rather than trying to take those tablets or the packets, since that makes patients so nauseous. So I'll try to kind of look up dietary sources of phosphorus-rich foods for them too. Things like potatoes also, I think, technically have a lot of phosphorus. So if you look kind of like things that patients on dialysis are supposed to avoid, a lot of them have high phosphorus, and you can help supplement that way too. And then someone is asking how the 125D distinguishes the renal leak of the phosphorus. And I was just going to go back. I really find this chart the most helpful. And let me just walk you through it. So if you have your serum phosphorus here, and you want to see PTH oftentimes can cause a little bit low serum phosphorus. That's normal. That's what happens if you have a high PTH level. It's inhibiting that renal reabsorption. So you're losing the phosphorus in your pee, in your urine. Think of it that way. FGF23 also has that same relationship. See, it's blocking it. It's inhibiting that renal reabsorption. But really what distinguishes FGF23 from PTH is what it does to 1-alpha hydroxylase. So if you, as a reminder, 1-alpha hydroxylase, what it does is it takes the 25 hydroxy D and adds a hydroxy group, and it's making it 125 hydroxy vitamin D, adding it to the rings on this compound here. So PTH is stimulating that enzyme, whereas FGF23 is suppressing it. And so that's where you see that differing relationship, and that you can use the 125D level to help distinguish it. So if you go back to this patient's original labs, they had a low phosphorus, a pretty unremarkable PTH. It's on the higher end of the normal reference range, but it's not above a normal reference range. The 25 vitamin D is nothing really remarkable. If anything, that's remarkable to me, the fact that it was normal, but it's not excessively normal and it's not very low either. And then the 125D, that it's not a really high range, which makes sense because the PTH level wasn't high either. So if you see a very low or a normal 125D, that's when you start to wonder if there's any FGF23 excess. Okay. All right, you are all pros now with this workup of this very uncommon condition, but it can happen. Okay. So I'll move on to the second case. And this is a 30-year-old female who's 20 weeks pregnant, and she's referred for hypercalcemia. Kind of like the case that I showed before, she also has nausea, fatigue, heartburn, constipation, and polyuria. She's also GTP1. She did have hyperemesis gravidarum in her first trimester. She has a history of multiple kidney stones, most recently 2 years ago. Right now, she takes a prenatal multivitamin that does contain 200 milligrams of calcium carbonate and 400 international units of vitamin D. She has Zofran as needed because of her nausea, and she does take an occasional TUMT because of that heartburn. For her family medical history, she has no known endocrine disorders. No one else in the family has kidney stones. On exam, her blood pressure is 90/60. Her heart rate is 124. She's well appearing, but she does have some dry mucous membranes. She's tachycardic. Her heart rhythm is regular, and her abdominal exam is pretty unremarkable other than being pregnant. It's gravid. So shown here are her laboratory values, and I'll just let you read through this while I take a sip of water. And pardon me, I'm just going to mute myself for just a second. I blow my nose, I'm getting over a cold. Okay, so let's walk through it. So if you saw, I had a similar set of labs earlier today. So now you're all pros in terms of how to interpret this. But just in case, so we'll walk through them. So you have a creatinine of 0.9. Bicarb is normal at 22. Her total calcium is 11.5. Albumin is 3.3. Iron is 0.8. Her phosphorus is 1.6. PTH is 100. 25 hydroxy vitamin D is 20. Our calcium is 500 and our TSH is 1.8. Does anyone want to say what they're worried about for this particular patient? Oh, I see someone already. I missed it. If you said it already. Primary hyperpara. Excellent. Yes, I agree. Well, so let's walk through it. How can we definitively say this if they have primary hyperpara based on this? So I want to review the same chart again. I love this one so much. I already said it before. But this one's by Dr. Cronenberg and Dr. Christopher Kovacs. If you didn't happen to catch my lecture earlier today, I'll just repeat it so everyone can hear, see this. I'm going to mute one participant one moment, please. Okay. And essentially what you see is that the x-axis here are the trimesters of pregnancy, first, second, and third. The gray zone areas to know if it's a normal reference range. So starting here at the top, the total calcium level, it actually decreased, and that's most likely a reflection of the decrease in the albumin levels that happen during pregnancy. So the albumin-bound calcium is decreased. And that's because you see that the ionized calcium level is actually unchanged. Phosphorus is unchanged. PTH also, it starts to dip down in the first trimester, it starts to come back up towards the end of the pregnancy. But in terms of why does it go down when, if anything, that you think that the PTH needs to be in overdrive? Well, 125 hydroxyvitamin E really kind of skyrockets. It starts to go up during the first trimester, and it pretty much stays nearly doubled throughout the course of the pregnancy. And that's because it's upregulation through the maternal kidneys of that 1-alpha hydroxylase, and there might be some contribution from the placenta, maybe from the fetal kidneys as well too. But this process really is what's really driving that calcium homeostasis between the mother and the fetus. Calcitonin also goes up, as well as PTH-RP goes up during the pregnancy as well too. So if what we expect to see during the pregnancy is that the ionized and the total ionized calcium should be unchanged, total PTH should be low, PTH should be low, that these labs are markedly abnormal. So I've also highlighted in here the creatinine. She's a little bit dehydrated. For someone who's 20 weeks or in their second trimester, their creatinine reference range really should be a little bit lower, more like 0.4 to 0.8, so she's a touch high. Bicarb is important because anytime you see hypercalcemia, you want to rule out any kind of routine or kind of more run-of-the-mill causes of hypercalcemia, such as milk alkali syndrome. You know, I put in a clue in her history because she has heartburn. She takes Tums, which here in the US is a common antacid that contains calcium carbonate. So if you're taking these calcium carbonate, extra calcium carbonate pills all the time, you could have milk alkali, but she doesn't have that. Her total calcium is abnormal since it's elevated. If anything, it should be low. Her albumin is a little bit low. That's okay, 3.83. Her ionized calcium is elevated though, at 6.08. Phosphorus is on the low side, but that's kind of more explained. I didn't put it in red because it's kind of like a appropriate low, given the fact that you see that this PTH is 100. So you know, I could put this in red too. I probably should, but I really wanted to highlight the fact that this PTH being high is abnormal for her. The 25 vitamin D level being 20, it's not that high, it's not that low. If anything, if it were higher, it might exacerbate the condition and make her hypercalcemia even worse. And as I referenced earlier too, the 24-hour urine calcium level, this is not on the high end, but it's not crazy high either, in the sense that because the 125 hydroxyvitamin D levels go up so much in the mother during the course of pregnancy, the urinary excretion of calcium also increases. It typically doubles or triples. So it's a little bit hard to interpret this value alone without the other test results. And her TSH was normal. Okay, so what additional tests do you want to order? You see this pregnant lady and she has primary hyperpara. So what do you do next for her? Okay, so I'll go ahead and answer. So what I would probably order is a neck ultrasound. You know, oftentimes we like to do different imaging at our institution, particularly a kind of a new hot topic one is a 4-dimensional or 4D CT. The fourth dimension is time, and it has a really nice resolution to help localize any kind of parathyroid abnormalities. Unfortunately, anything with kind of radiation, CT scans, that would be contraindicated in someone who is pregnant. So neck ultrasound would be your next choice. All right, so what treatment would you recommend? Would you pick A, oral hydration and continue to monitor, B, Sinistar Cinacalcet, C, IV hydration followed by furosemide, D, IV hydration and start an anti-absorptive, or E, IV hydration and refer to surgery? So I'll let you think about that for a minute. Okay, and so if we walk through each of them, we'll just go through each one. So what would happen? So if you pick A and you chose oral hydration, continue monitor, I think you can't go wrong with that, right? Like no one's going to tell you not to tell her to drink more water. That's what a pregnant woman does. She's thirsty. She's going to drink more water. That being said, let's say it doesn't work. Okay, we're stuck. We're still in the same spot. Maybe her calcium got a little bit better, but let's say it's still elevated. Would you want to start cinacalcet? Maybe, in theory, it could potentially bring down the calcium level, so that will make you feel better about the number. But I think cinacalcet, it's a pregnancy class C here, so there would be concern that it causes any kind of negative side effects to the fetus. So personally, I think unless I was really in kind of an emergent situation, that would be a medication that I would avoid. The next choice would be IV hydration followed by furosemide. I think it's not a terrible choice. You would have to definitely, I would recommend doing it in that order of the IV hydration first, because you want to make sure that they're volume replete before you add on something like furosemide to help with the calcium levels. The concern there would be, she's only 20 weeks along. You got a long ways to go if that's going to be enough to help manage her throughout the course of the pregnancy. I say, okay, well, if you're worried about short-term care, what about a longer-term choice? IV hydration, steroid anti-absorptive. It's kind of the same thing. There's a theoretical concerns of any negative effects of the bisphosphonate on the fetus. As I do have some hesitations, given that there is an alternate that I'm about to talk about. That being said, I will say, on a separate topic, when patients are, when you're considering starting, say, bisphosphonate in women who are of childbearing age, there are case reports of women that do okay. That, whatever the reason they either accidentally had it or they decided because they were so risk. I will say that there are case reports here and there that it's okay. So you might want to consider it in patients who are high risk. But for this particular scenario, since you do have an alternative, my preference would be IV hydration, refer to surgery. Obviously, sending a pregnant person to surgery is never ideal, but you're kind of stuck because she already has hypercalcemia and she's already in her second trimester. If anything, would you view the fact that she's in her second trimester good or bad? So would your recommendations change if she were in a different stage of her pregnancy? Say she were in her first trimester or her third trimester? And what are the risks if you delayed the surgery to the postpartum period? What are the risks to the mother and what are the risks to the fetus? And I'll just pause for a moment because I finally realized that more comments were coming into the Q&A that I hadn't realized. I thought it would automatically push things down, but I didn't see. So thank you for those participating about offering the ultrasound. For an MRI, I'm not familiar with any kind of imaging that is sensitive enough for specifically parathyroid. I'm sure that it has been done, but I'm not familiar with any kind of specific MRI imaging that is great for localization of a parathyroid. So I would probably shy away from that one. What about FHH in pregnancy? That one you can always have concern about hypercalcemia. For her, I think it'd probably be difficult to interpret that again because as we say that the 24-hour urine calcium levels get so high. I think for her, I'd be pretty reassured with a 500 level. It's not, but it would never hurt to do. I was blinking at not the creatinine clearance, but the maybe it is the calculation of seeing what it is. You could always run the numbers of what that ratio is, but I think less of a concern. How would you make the diagnosis since the calcium is increased in pregnancy? For this particular patient, really, I would say that the diagnosis was made really solely on the fact that the PTH was high and the calcium was high. So going back to that chart, what was the point I wanted to say? So how would I make the diagnosis if it's increased during pregnancy? My whole point was ionized calcium should be unchanged during pregnancy. So the fact that you see that the total calcium and the ionized calcium are both high, that already there is abnormal. And the fact that if you have a high calcium and a high PTH, that's your biochemical definitive diagnosis of primary hyperparathyroidism, because if your parathyroid glands are doing their job right, they should never be high if you're in a state of high calcium level at the same time. They should just really turn down their production of PTH and be like, hey, I'm not needed right now. I don't need to increase anything. So that tells you that, whether it's 4-gland hyperplasia or a single gland adenoma or multi-gland adenoma, that tells you that something is going on there. The PTH regulation is not correct as a response to the hypercalcemia. So that's your diagnosis. You're right. The 24-hour urine calcium level, it's not definitively contributing to the diagnosis, but it's also not negating it. I guess it's not contradictory towards it either. Okay. And then coming up to the most current comments, I think, make sure I'm caught up to that. And I agree, second trimester is the best time for the surgery. And why is that? So the concerns would be that the risks to her, if this was diagnosed during her first trimester, is miscarriage. Just statistically speaking, there's more rates of miscarriage during the first trimester. And during the third trimester, you worry about kidney stones and preterm labor. In terms of the risks of delaying surgery to the postpartum period, let me just go ahead and mute. Okay, there we go. Thank you to whoever did that. The risks to the mothers would be kidney stones, preterm labor, hypercalcemia requiring urgent surgeries, nothing that you want. No one enjoys that at any stage during the pregnancy. And then a big concern is the risk to the fetus of severe neonatal hypocalcemia. So if you can imagine that the mother's calcium levels, their circulating levels, are quite high, it actually would end up resulting in suppressing the normal development of the fetus parathyroid gland. And so then when they're born, they're not like bathed anymore in their mother's hypercalcemia levels. They're supposed to be on their own, but their gland wasn't well formed. So they are at risk for severe neonatal hypocalcemia. So ideally, you do want to try to address this before delivery if possible. There are thought to be fewer rates of complication during the second trimester. But obviously, if patient wasn't comfortable or it just wasn't possible for whatever reason, if it needs to be done during third trimester, then it would just have to be a risk-benefit conversation between patient and all the providers involved. Okay, so really the takeaway points for this particular case are understanding the typical physiologic changes in pregnancy, that there should be an unchanged ionized calcium level. You do expect to see lower total calcium levels and that there is normal to have increased urinary calcium. Okay, before I move on, any questions about that case? Oh, sorry, I missed a couple one. Is the neonatal hypocalcemia transient? Oh, shoot, I'm not sure. As an adult endocrinologist, I need to follow up. I'm not sure. And when I follow this case without surgery, if calcium is less than 11.5, I think that would be a tricky one. I think you'd have to see what the patient's symptoms are and what the degree of if you had a pattern of the changes of the calcium levels, that would be helpful. I think that one is really difficult, but depending on how comfortable you are with the surgeons and your institution, you might prefer to do advised surgery during the second trimester because of all those potential risks that I just outlined, because you don't want to get too late. Essentially, you don't want it to kind of get out of hand. So I think it might be a matter of you could follow it too to see how quickly it's changing. But if you felt comfortable with expert surgeons that they could do the surgery in this patient, then it might make sense to go forward with it anyways, because they could develop those complications later. Okay, any other questions? Okay. All right, so we're going to move on to
These grays on the way. I gotta go take some. Okay, good then. Good. Are you trying to take? No, take this.
Hello.
I'm gonna tell that stress. Finish your state. And it's watching now the section.
I can't see anyone to mute. Again, my apologies if I'm muting you and you're trying to ask a question, but okay. Okay, so my last case is going back to osteoporosis. As you might have guessed in my lectures today, osteoporosis is really very near and dear to my heart. So we'll just dive right into it. So I have this case of an 80-year-old woman, and she presents with an L2 compression fracture after a fall. Her DEXA is notable for having a PA spine T-score of -3.1, a total hip T-score of -1.6, and a femoral neck T-score of -2.1. So what would you choose? I'm curious. Why don't you go ahead and put it in the chat? I'm curious what people would choose. Actually, as people put in their answers here. We got some for Prolia, some for anabolic. Okay. Interestingly, none for bisphosphonates. So I'm actually going to go through most of them as if hypothetically, let's see if you chose it. Okay, so let's say you chose bisphosphonate. And the whole point of this last series of slides that I have here is to really get you thinking about this idea of sequential therapy. Let's say you had picked a few years of bisphosphonate therapy and then what? And I would say, honestly, I would say probably for, I don't know about you, this is probably more likely where you already had someone who on bisphosphonates and then you're like, okay, now what? Maybe their PCP is like, oh, they fell and they broke their back. I already had them on alendronate on the Fosamax. Now what should I do? Then what would you do after this? We'll go ahead and type in some answers. Okay, so I don't see any particular answers, so I'll just go ahead and move on with the slides to kind of let you know, well, what would you expect to see? So just really kind of breaking down this idea. I know Dr. Leader had introduced the idea of sequential therapy in addition to combination therapy. And I don't know about you, but he covers such a large amount of information that I always find it helpful to have it repeated. And so I wanted to break down this idea of what happens when you do with the different sequences, when you switch from one category of osteoporosis medication to the other category. So this slide is, what if you're on anti-absorptive first, and then you move to an anabolic? And what I can show you is this has been done before in a clinical trial. So this one was an 18-month trial. And it was women who had who had just by chance or just their history, they had already been on raloxifene or alendronate for a range of 18 to 36 months. And then they were randomized to, and then they were assigned to receive teriparatide. And what's interesting is that over the 18 months of that teriparatide therapy, PA spine does increase. But those who had been on raloxifene before had greater increases compared to those that had previously been on alendronate. And you have a similar pattern here at the hip, where those who had been on raloxifene, they do have some increase in the hip and pretty much nothing if you had been previously on alendronate. And so this is getting at this idea that an anti-absorptive therapy can blunt your anabolic response. And so that begs the question, does the order of the medications make a difference? And it seems like it does when you pull through all the different literature. Essentially, when you switch from a bisphosphonate to an anabolic drug, that actually results in transient cortical bone loss and blunted bone density gains, at predominantly trabecular bone sites like the spine. So what I just highlighted here in this transition study where people had been on alendronate for 29 months and then switched to 2 years of teriparatide, when you take a look at their total hip bone density changes while on therapy, 6 months into teriparatide, it actually goes down by 1.2%. Then it starts to come back up to negative 0.6. Then it starts to increase above, and then it goes up by 2.4. So you actually have this, not just a blunted bone density gain like we saw at the spine in the last slide, but actually transient cortical loss. You can see that at the hip. So just keep that in mind if you're switching from a bisphosphonate to an anabolic therapy. I think if I were to think of one kind of specific clinical scenario that's most going to be applied to someone, say, with like a hip fracture, I wouldn't go thinking, oh, someone who is on zoledronic acid with a hip fracture, they failed with zoledronic acid, I got to add an anabolic. I'm not so sure I would go with that choice because of this issue of the transient cortical bone loss. Okay, so let's say you had them on denosumab, and after that, then what do you want to choose? What would you guys pick for that? I'm seeing if anyone has something. Okay, so I'll just keep going through the slides. And just really highlighting again this idea that there's this rapid bone loss after discontinuing denosumab. In this trial of postmenopausal women that had 2 years of denosumab, compared to this line here in placebo, here at the lumbar spine, you can see it goes all the way back down to baseline of their lumbar spine bone density within a year after stopping the denosumab injections, and that's sustained for additional year. Same pattern here at the hip. It had some nice gains, up almost 4% over 2 years of denosumab, and then within a year of stopping it, they're really back at baseline, and if anything, slightly below their baseline here afterwards. They are still higher than the placebo group, which is how it had been interpreted back at the time of the publication, like you were still better off than if you were on nothing. But as you know, this increased risk of multiple vertebral fractures after stopping denosumab now precludes the use of just stopping denosumab without any kind of follow-up therapy. So I did want to highlight again, I think Dr. Leder had shown this slide, but what would happen if you were to switch from denosumab to teriparatide? We had conducted this trial, the data switch trial, as postmenopausal women with elevated fracture risk, and they were randomized to receive 2 years of either teriparatide, denosumab, or both. And I want to just highlight the switch group here of those that were on denosumab for 2 years and they received teriparatide for 2 years. And what you see kind of similar to that blunting effect that I was saying of between bisphosphonates and anabolic therapy. Here, the denosumab to teriparatide group is here in blue. So for 2 years, you can see nice increases at the spine. And then there's a little dip right here. Let me get my cursor going again. There's a little bit dip right here before it starts to climb again and catches up to the combination group. Here at the total hip, on 2 years of denosumab therapy, there are some increases, but then it goes all the way back down to baseline. And this isn't on zero therapy. This is with them taking something. They are taking teriparatide. So despite taking daily paratide, on average, their bone density goes back to their baseline before starting to climb again in the second year. And then more concerningly, or also concerningly, here at the radius, which is always a more modest site in terms of response of bone density changes here, you can see there were some increases in the denosumab, but then actually progressive decrease when switching over to teriparatide. It never actually changed the pattern there. When you take a look at the bone turnover marker levels also, again, focusing here on the blue line, the osteocalcin is a marker of bone formation, so it's very much suppressed, but then markedly elevated when they switch over to teriparatide, and the same pattern here that you see with serum CTX, a marker of bone absorption. And what's really striking about this is that even though I had mentioned earlier, very briefly, very cursorily, that teriparatide is what we call a pro-absorptive medication. It's known to be anabolic, but technically speaking, if you look at their bone turnover markers, say this is group A, this red line here are those who had started on teriparatide at the beginning of the study. There is increase in the CTX level here and also the osteocalcin level, but the degree of the increase of CTX and the osteocalcin is much greater than if you had just started teriparatide de novo as a treatment naive patient. So there is something about this transition from denosumab to teriparatide that results in very active bone turnover. So how best to transition from denosumab? There's been very inconsistent case reports of the effect of bisphosphonates after denosumab, as you all have seen. Again, I won't spend too much time on this because I know Dr. Leder had already gone through this one. But we had done a second iteration of our data trials of a high-dose teriparatide, and in women who had received teriparatide overlapping with 1 year of denosumab, they received a single dose of zoledronic acid and then followed for approximately 2 years or 27 months. And you see that the single dose of zoledronic acid was able to maintain bone density, at least for the first year, with a little bit drift down by month 42. But it was maintaining bone density at the total hip and the femoral neck. That's contrast, though, to other studies on zoledronic acid, just to let you know. So this one, it was a postmenopausal woman who had been on denosumab for a mean duration of 2.2 years. They did achieve osteopenic range bone density, and then they were randomized to receive either a single dose of zoledronic acid, 5 milligrams, or 2 additional doses of denosumab, and then follow for 2 additional years. And this was before everything was aware, so it was ethically, it was still considered okay to do. I apologize, I've meant to label these, but the single dose of zoledronic acid is here in the open circles here for lumbar spine. So you see it doesn't dip below. But then when you stop and you only got the 1 year of the denosumab, then it plummets down below for the spine and the femoral neck. So this one was kind of like, oh, well, the zoledronic acid, it does maintain the bone density. It didn't take a nosedive down. But I think the most concerning one is actually the most rigorously and the most complex trial that we have. It was a trial of 61 postmenopausal women with osteopenia. It's a 2-year randomized control open label. They had been on what's a notable difference. A mean duration of denosumab was a little bit longer. They'd been on it for 4.6 years. Zoledronic acid. The study design is that they were then given zoledronic acid either at 6 months when they would have been due for the next denosumab dose, or they delayed it on the idea of saying, oh, maybe you need the bone to kind of like wake up and you want to catch that rebound phenomenon and then tamp it down with the zoledronic acid at 9 months, or wait, you're going to use the bone turnover markers and wait. And they had some certain cutoffs and rules in terms of depending on how much it increases by, then they're going to give the zoledronic acid. And what was really disappointing is across the board, no matter what you did, it didn't maintain it. So lumbar spine decreased by 4.8, 4.1, 4.7% across the 3 groups. Total hip decreased by 2.6, 3.2, 3.6. It was quite disappointing that kind of no matter what you did or when you gave it, it didn't maintain it. And it was striking that it was really contrast with the other studies I was showing you. One other trial here that I'll show here is the DAP study. It was trying to evaluate how if patients prefer denosumab or alendronate. And it was a 24-month randomized crossover as a comparison of women receiving 1 year of denosumab and then 1 year of alendronate or vice versa. For the purposes of this topic, if we really focus on just the denosumab to the alendronate group that you can see in months 0 to 12, when they're just on the denosumab, they have some expected gains, 5.6, 3.2, 3.1%. And then when they switch to the alendronate, it doesn't go down. It's pretty much maintained, 0.6, 0.4, negative 0.1%. So that's again pretty good. So how do we put all of this together? You know, I showed you this one looks okay. This one doesn't look okay. This one's like, sure, I wish it were better, but it's okay. And then our group, not bad. You know, spine's pretty good, still pretty high. Total hip and femoral neck is still pretty high too as well here. What I think a key difference is if you look at the duration of denosumab. So in this trial, these women had only received 1 year of denosumab and it had overlapped with some anabolic therapy. This trial, they are on denosumab mean of 2 years. This one they were on, this was the longest, a mean of 4.6 years. And then this one was actually only 1 year. So during our Q&A when we're talking about, you know, I kind of posed that question to the panel of, you know, what's your ideal duration of denosumab? While there is the safety data for up to 10 years, at the same time, you know, you still worry about those risks of osteonecrosis of the jaw, atypical femur fracture that happens with the longer term use. And then when you pull together all these studies, it looks like that it is harder to figure out how to transition off of denosumab if you've been on it for longer. It's really the only thing as a pattern to say like, when it did work or didn't work in terms of maintaining bone density was the duration of the denosumab. And so that's why a lot of us in our practice, one, we've been using it less, but two, definitely have been peeling back in terms of how long you might have the patient on it for. Which I have to say, it's disappointing. When you're on it, it works great. A lot of us have seen those graphs of the bone density changes when you're on consecutive years of denosumab. It keeps going up and up and up. So it's like really tempting to keep them on it so you can achieve greater bone density gains. But at the end of the day, I don't want them on it continuously unless it's like an older patient with no plans to bridge to no other therapy. So just keep this in mind. This is what we know out there in terms of duration of denosumab and the transitions with it. Okay, we're headed towards the home stretch here. I know it's been a long day for everyone. So what would you choose? So let's say you start with anabolic. A couple of you had said, I want to do anabolic therapy first. Well, actually, I forgot. I meant to put this in the Q&A, but I know Dr. Leader had to answer it. Someone asked, what's the longest that you use it on there? So at least in the US, in the terms of the original trials, teriparatide was studied for out to 24 months. Baloparatide, their phase 3 trial, was studied for out to 18 months. While that black box warning in terms of the risk of osteosarcoma has been lifted, presumably cumulative dose of the medications would be more worrisome, and the black box warning has been lifted, so that's good. At the same time, it hasn't been shown to be efficacious beyond the 18 to 24 month period. So personally, even though I could, in theory, maybe prescribe it for a little bit longer, my plan is not to do a short course or a limited course of anabolic therapy and then move on. So what would you move on to? Okay. So one thing to keep in mind is, as we already mentioned, that there is known bone loss after discontinuation of PTH. So this is actually an older study of PTH 1 to 84, rather than the current iteration of teriparatide of 1 to 34. And you can see that when they switch to placebo in their second year, it does drift down. It's not as dramatic as, say, when you stop denosumab, but it does go down. Which is interesting that there's actually some sustained vertebral fracture risk reduction, even up to 18 months after you stop it. So if for some reason you weren't able to get your patient onto some follow-up therapy right away, you could be reassured that they still do have some protection from that teriparatide course. But again, ideally you want to help maintain their bone density gains. Okay, so what we know is, at least for abaloparatide, that was the PTH-RP analog. They did do an extension trial where they invited those in the placebo and the abaloparatide group to be switched to alendronate. And what you can see is it does pretty well. It's not a bad regimen. So let me walk you through it here because the text is pretty small. But in this top right-hand corner here is the lumbar spine, and the dark line here is abaloparatide. And the dash, they switched over to alendronate. Pretty good. That helps maintain it. Even some subtle increases. Same thing here. The total hip looks pretty good after the switch. Femoral neck looks pretty good. What about teriparatide denosumab? As we know, denosumab and bisphosphonates, while they're both potent anti-absorptives, you can't treat them the same, so you always got to double check. So in our data switch trial, that particular group of teriparatide denosumab is here in red. And rather than bore you with this, because I know it's hard to kind of, after a while, it's hard to keep all these numbers straight. Essentially, I'll say the bottom line is good. The spine, you can see, keeps going up, 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 up after the transition. Total hip, if anything, teriparatide's pretty modest effects at the total hip, but then it does start to increase when you switch over to denosumab. And then at the radius, there's following this red line where when they're on teriparatide, it actually decreases it because teriparatide can have some negative effects on the cortical bone. And it starts to bring it back up towards their baseline once they switch over to denosumab. The very last one, romosozumab, Ben did, I think he did touch upon this very, very briefly. What's interesting is that romosozumab, because it's this unique dual action where it increases bone formation, as you can see by P1NP early on, but then that effect starts to wane, at least when you measure it by the markers. It's really more kind of like a moderate anti-absorptive afterwards, which is interesting because it doesn't really match the very impressive bone density gains that are sustained throughout the course of the whole 12 months. But because you see this waning effect, the original trials were always designed as a sequence. So the original FDA frame trial was enrolling 7,000 patients, and they received either placebo to switch to denosumab or romosozumab switch to denosumab. And what you see is pretty good. So when you go from the solid line here, romosozumab, to the dashed, this is lumbar spine bone density. You can see that it continues to go up, up, up. Here, the total hip, same thing, continues to increase. Femoral neck also continues to increase. That's a great sequence. Same thing in their ARCH trial, where they compared actually head-to-head of alendronate versus romosozumab, and then everyone during the open label period received alendronate. Again, it's pretty good. You can see increases here in the solid line of romosozumab for romosozumab. Not quite as impressive, I'll say, as when they switched to denosumab, but it's maintaining. You know, I'd argue that they had such impressive gains over just a 12-month period of 13.7%. You know, like, it's not bad to keep it where it was. And same thing here for total hip. So where does that leave us? I go back to this original case, an 80-year-old woman. She had an L2 compression fracture after a fall. She does have significant osteoporosis at the spine, osteopenia at the hip. To me, they're actually all pretty reasonable sequences. You know, if you're like, just get on something. If you can get on once a year IV zoledronic acid, fine. And then we have to switch you to PTH at some point, that's fine. You know, probably less likely, but, you know, it's not the end of the world. More practically speaking, she'd probably be on, say, IV zoledronic acid, and then keep her on the course, and then a drug holiday. For those that voted for analogs, say PTH analog or romosozumab, I think also excellent choices too. You know, of one versus the other, hard to say at this point. If you're comfortable with romosozumab, you know, they have some really robust gains. I think the nice thing about romosozumab is that it has really nice gains at both the spine and the hip, whereas as you saw, the PTH analogs, much more modest at the hip. So if I were really worried, you know, you might go with the route of starting the romosozumab first. For those that chose denosumab, you know, it's not a wrong choice. Like I said, though, personally, I've been shying away from it just because I think it's so difficult to transition off of it. And I think there are other great choices in the sequences. So it hasn't been my go-to, but I do know that it would be efficacious in terms of improving bone density, and also has proven anti-fracture efficacy. Really what I wanted to highlight in this clinical case vignette, though, is really, I try to avoid this transition here, denosumab to PTH analogs. I'm really just hammering home this idea that if you have someone who's on denosumab, and at some point when you decide to stop or transition off, it has to be some type of anti-absorptive, not to an anabolic therapy. Okay, and I think I already just summarized all those points. Any questions? Let's see, I apologize. I keep seeing these come up, but I don't see it move, so I didn't think anyone's on there. Let's see, so if someone develops an atypical fracture on Prolia but can't afford teriparatide, should I give raloxifene? You know, I'm not a super big fan of that. I think maybe something is better than nothing, but it's probably not enough. As I think my short answer to that. You know, I really write as strongly as you can to help persuade whatever company it is that could help you afford the teriparatide for them in that particular case. You know, raloxifene doesn't even have any proven benefit for hip fractures, so I think it'd be a real shame to move a patient to that. What's wrong with denosumab for 10 years or lifelong? Well, there's no safety data beyond 10 years. To me, my concern about, because there's no safety data beyond 10 years, I'm not comfortable beyond 10 years. In their extension trial too, those patients still continue to sustain osteonecrosis of the jaw and atypical femur fracture. So if I think of it with, say, bisphosphonates, you know, I don't like to keep those patients on 10 years or longer because of the same side effects. So I'd have the same reservations. For lifelong, I would only consider it if it is, say, an elderly patient at high fracture risk, and I think they could be on it lifelong based on their life expectancy. In my own practice, when do I switch from Prolia to another agent? I've been trying to, because I'm so concerned about long-term side effects of the ONJ and AFF, I do kind of stick to a general 5-year of anti-absorptives. So I start to talk to the patients switching around year 4. even year 3, if I think that their bone density is okay, they're not so severely low. Because I always think of it, I think I saw Dr. Leader given his answer, how much follow-up anti-absorptive therapy do you give? Even that is not a question that's clearly defined, is it 1 year, 2 years, 3 years? What I can tell you is that the incidence of the vertebral fractures observed, I think on average, as soon as 7 months after the last injection, so essentially 1 month late, so pretty early, or I think it's about, I got to double check the package again, but I think it's about 1 year after, a little bit over 1 year. So in general, I've been saying for sure at least 1 year's worth of therapy, potentially even 2. So if I'm trying to get a patient on a total anti-absorptive course of roughly 5 years, I'm going to stop around year 4 or even year 3 if I wanted to keep it at 5 or cap it at 6. Can you use romosozumab in patients with moderate or advanced renal failure? The company, they did put out, I think it is published now at this point. They had a subset of patients in their original trial that had, I believe, some mild CKD that kind of got through with their eligibility criteria, not advanced, and it was found to be efficacious. I think it's hard to know what to say for the advanced renal failure, though, if it's going to be efficacious for those or not. In my own practice, when I switch, what do I do? Which one's my suggestion? I think practically speaking, a lot of them that I had were on Prolia because they didn't tolerate an oral bisphosphonate. So IV bisphosphonates have been my go-to in general. That being said, I do find the idea of alendronate very appealing in the sense that you have kind of a continued exposure to bisphosphonate. So if I think that they're not so high risk or their bone density results could tolerate it, sometimes I do toy with the idea of alendronate as well. If a patient is switched from romosozumab to denosumab, how long would it be given? Would they be at risk of vertebral fracture? Stop denosumab. So in terms of how long to be given, that would just depend on your clinical course and their bone density changes, the same as you would for any other kind of osteoporosis care. And they would be at risk of vertebral fracture if they stopped denosumab without any other follow-up therapy. Is it better to switch from Prolia or denosumab to bisphosphonate or romosozumab? There's pretty limited data about switching from denosumab to romosozumab. I think to my knowledge, the last I looked, there's only a couple of cases or I think a handful of reports that have talked about it. There's one nice randomized controlled trial, I think, that had it. It looked promising, but it was pretty shorter term use of denosumab. So I think it's hard to interpret. Pardon me, sorry, I'm getting over my cold. Last one, if someone has a lot of symptoms with oral bisphosphonate, like body pain and dizziness, would you consider an IV bisphosphonate, or do you think that would cause more serious symptoms? It's a tough one. I think if you're very clearly that you think it's related to the oral bisphosphonate, I would have reservations about giving them the IV bisphosphonate. That being said, I think depending on the severity of it, you could see if your patient is willing to try a very low dose. And when I say low, you could even go as low as 1 milligram, 2 milligrams, stretch out the duration of the treatment and see how it goes. But you just have to have the conversation, it's an IV drug, so you can't undo it once you do it. So you wouldn't know. And I don't think it's kind of one of those unanswerable questions. It's hard to say for sure. Okay. All right. Well, I want to thank everyone for your time, and I truly appreciate your attention. Thank you so much.